Welcome to the 49th Annual Garland Lecture, which will be given by Dr. Paul DeChant on physician burnout. It's time for a new approach. The Garland Lecture was named in memory of Joseph Garland, who was an editor of the New England Journal of Medicine for 20 years, and then was the president of the Boston Medical Library for 4. Next slide, please. Oh, sorry. I'd like to thank the members of the Garland Lecture Committee who planned this lecture. Continuing medical education is important to many of us. An evaluation survey link will be emailed to you tomorrow to receive 1 credit of CME. If you return the completed survey, the BML will inform UMass Chan of your attendance, and the medical school will issue a credit certificate. The BML is pleased to be able to offer this CME opportunity free of charge. There are additional benefits for BML fellows and MMS members, and these include access to the resources and expertise of the staff of the Lamar Suter Library at UMass Chan. Current library services is very difficult for practicing physicians who don't have academic appointments, and I think is a real opportunity. Please consider becoming a fellow of the BML to support this endeavor. This lecture today is the 49th Annual Garland Lecture. Dr. DeChant will be speaking on preventing burnout, and he has been working in this area as a consultant for the last decade. He started out in family practice and then moved to clinical leadership, where he developed a happy group practice, improving physician satisfaction remarkably. So he is experienced in this area, and I'll introduce him now. Dr. DeChant.
Well, thank you, Dr. Peters. I really appreciate that. And I appreciate both the people, especially the people that are here live in the audience, as well as the people that are online. I've been looking forward to this for a long time, for a chance to help spread this word about physician burnout, thinking about it in a different way, because it's time to take a new approach. Burnout has been around for decades, and it certainly has gotten worse over the last 4 years since the pandemic. And prior to that, it had been increasing for another, probably the 10 years prior to that. And we'll get into all of that. Typical for a CME talk, we start with the objectives, which honestly, many times when I hear a lecture, I say, I hope the objective slide, people just get through that. I really want to get to what people are going to talk about. We know you have to have objectives to get CME, but the objectives here, I think, are truly important because we're going to deep dive into the connections between the drivers of burnout and how we experience burnout and how that plays out in clinical settings. We'll identify key leadership opportunities to change the conditions in the workplace that drive burnout and evaluate a level of urgency that's needed to respond to this workforce crisis. We hear a lot about burnout. At some point, people are just starting to get burned out talking about burnout. And we're not necessarily approaching it with a level of urgency that honestly we know we're capable of. In terms of disclosures, I'm an advisor to a couple of organizations that are really not pertinent to the presentation. But to get started, I think for me, one of the things that always strikes me is that as physicians, we should have the best job in the world. I mean, what other profession do you have where people will come to you and share with you their deepest, darkest secrets? They'll tell no one else in their lives because they trust you to have your best interests at heart, their best interests at heart. Or they trust you so much that they let you stick needles in them and cut them open because they know you're doing that work to make them better. You get to mentor young people as they prepare to become your colleagues. And you get to work on process improvement and innovation to improve healthcare delivery. We have so many opportunities for professional fulfillment. And yet over half of us are burned out. You stop and think about that, it almost doesn't make sense unless you've been in the trenches. Because we know we're spending only 1/3 of our time on that meaningful work, that thing that gives us professional fulfillment. And 2/3 of the time, it's caught up in administrivia, things like typing data into the EHR, fighting with an insurance company about a prior authorization, running around the clinic or the hospital, trying to find the equipment or the supplies or the staff support that we need. So many barriers and frustrations that get in the way of our professional fulfillment. We're often offered, when we get burned out, we're often offered resilience support, which is needed, but really, this problem is not one of a lack of individual resilience. Physicians are some of the most resilient people in the world. When you think about what we go through to get into medical school, to get through medical school and residency training, and what we do in our professional lives, there's not a lack of individual resilience as the key issue. The key issue is that the problem with burnout is the workplace itself. In fact, the World Health Organization says as much. In ICD-11, it calls burnout an occupational phenomenon that has 3 dimensions, the first of which is exhaustion. You've given everything you've got. You've got nothing left to give. By the end of the day, you're completely wiped out. Your resources are depleted. And by the next morning, hopefully you've recovered. But as you do this day after day, week after week, you get to the point where first thing in the morning, you still have not recovered. You're still depleted. At that point, we start to protect ourselves. It's a natural reaction. And it shows up as cynicism or depersonalization, where we're distancing ourselves from our patients, from our organization, from our colleagues. And when we put those two together, we start to wonder if we're making any difference at all. It's a gnawing sense of inefficacy, that what we're doing really doesn't matter. And that can show up in one of the most unique situations where you have 2 people together in a room, a patient and a physician. The patient finding great value from that interaction. At the same time, the physician's mind is thinking and wondering, am I making any difference at all? You just think about that interpersonal interaction and what happens there. These 3 dimensions of burnout were first identified over 40 years ago by researchers Christina Maslach and Michael Leiter. And they also identified 6 drivers of burnout, the first, which they describe actually as job-person mismatches. The first of those is work overload. And I don't think anybody here will be surprised to hear that what they showed was work overload, well, it drives exhaustion. No way, really? I'm surprised. I don't think I could have figured that out. We all could have figured that out. But the problem is that's where most of us stop. We think this is what burnout is. I'm overloaded and I'm exhausted. And there are efforts to deal with this particular aspect of burnout by redesigning workflows to reduce the wasted work, to give us an ability to spend more time focused on our patients, more time improving productivity, and when we do it right, we can actually increase work-life balance while we increase productivity. And that can be dicey to say because so many physicians are so burned out and so stressed. The thought of saying we're going to focus on both at the same time really worries them a lot. They think this cannot be done. And I understand that because we have to be careful. Work-life balance is so out of whack that we have to focus there. But if we do it right, we can accomplish both. So this is what most people think burnout is. What most people don't know is that there are these 5 other drivers of burnout. The first of which is lack of control. That's a pretty big deal to physicians. We are trained to be autonomous. We give up the decade of our 20s to get the knowledge and skills we need to take control when people want us to be able to take control in a crisis situation. And yet we live in this world where often we don't have control. We don't have the autonomy over what we do or how we do it to fix the stupid stuff that we know could be better. And we have ideas about how to fix it, but it's denied us. In fact, control is one of those intangible rewards we look for when we join the profession. And insufficient reward just happens to be the next driver of burnout. Along with control, there's just simply appreciation. You work hard, you do amazing work. Do people understand what you're doing? Do they thank you for the work that you're doing? Or do you go through that whole day, and at the end of the day, even though you know you've made big differences in people's lives, people do not recognize it or appreciate it? One other intangible reward that I certainly found valuable was the collegiality and connection with fellow physicians, with nurses, and with others. And breakdown of community is the next driver of burnout. That loss of collegiality, that loss of connection. Prior to the pandemic, we were dealing with that as specialties got more separated and physicians were either in the hospital or in their offices, but oftentimes not coming together, or people were just so busy, we never even got a chance to sit down together to a meal. With the pandemic, obviously, it exploded in spades, and now with remote work, it's a real challenge. But even when people are together in the same room, too often, people are more focused on their devices than they are on each other. You can go to any hospital and walk around a medical ward and see the hospitalists in a room. Maybe they're all sitting in this room together, but are they interacting with each other? Quite often, they're interacting with the EHR, trying to get their notes done because there's no time to actually connect to each other. The next driver is absence of fairness. When you are treated differently or opportunities are denied you, not based on the quality of your work, but based on things that you have no control over, such as your gender, your race, your country of origin, your age, or your sexual orientation. All of these things contribute. We lose so much value from people who get denied opportunities. And lastly, values conflicts. When your deep personal values don't align with and agree with those of the organization with which you work, or when you have to participate in or even witness activities that violate your personal values. This happened so often during the pandemic. Not really a choice we had even, it was the case of what was happening. So these are the 5 other drivers of burnout. And they have everything to do with how you lead. Whether you're supervising a team as small as 2 or 3 people, or you're the CEO of a system with 20 or 30,000 employees, when you lead in a way that exacerbates these drivers, when you micromanage, you actually drive cynicism and disengagement. A lot of people don't know any other way to lead because that was the leadership example that they had when they first moved into their leadership position. And by gosh, their boss is holding them accountable to deliver on metrics, and they're going to have to do that one way or another. And the only way they know is to be a micromanager, top down, and drive on these issues. But it doesn't have to be this way. When people learn proper ways to be a servant leader, we can change culture by empowering people to have control over their work and align them around the values that bring meaning to us and get great engagement. Those same drivers actually line up incredibly well with Maslow's hierarchy of needs, starting with physiologic needs, aligning with work overload. We can just ask everybody in the room here. Have you ever worked so hard that you had struggles maintaining and caring for your own physiologic needs? Have you ever spent so much to do, so little time to do it, that you skipped a meal because you didn't have time? Just raise your hand real high if you've ever skipped a meal because there's too much work to do. Now keep your hands up if you've ever missed sleep because there was just too much work to do. And one last one, and this is the most important. Have you ever held your pee because there was just too much work to do and not enough time to do it? I mean, we are stressing our physiologic needs out, and it's hard to keep moving up Maslow's hierarchy. But next is lack of control, which has huge impact on safety. Breakdown of community impacts love and belonging. Rewards and fairness have a deep impact on esteem, and conflicting values impact self-actualization, which we can think of as that professional fulfillment. One of the challenges, particularly when we think about the top of the triangle here, those top two lines, one of the controversies in burnout right now is burnout even the right term to be using? Or is there something else going on? Is it really moral injury that we should be talking about? And does burnout even care about moral injury? This was recently published in the New England Journal. And when you dig deep into it, I know it's hard to read on the screen, but it basically says that burnout has ignored these moral issues, has ignored values, has ignored fairness. But we've just seen that actually over the past 40 years, Maslow and Leiter have actually worked through that in great depth. So we have this opportunity to choose. Do we split this whole committee, this whole community working on this issue into moral injury versus burnout camps, or do we find the way to work together because they really are intimately involved? Let's step back for a second, though, and talk about how burnout got to be so bad. Remember, it's not the doctor. The problem is not the person. Physicians are resilient. The problem is the workplace. And how did that workplace get to be so bad? Well, there are all of these external factors that have impacted it over the last 20 years. Starting with our friend, the EHR, which when it was first introduced, had the pleasure of being accompanied by meaningful use, and particularly into coding issues with very detailed coding, which in order to get billing done, which the payers love because they can then deny payment or demand prior authorization. The government said, well, let's help. Maybe we can make this better. Let's look at value. So we included patient satisfaction as a way to measure value. And I don't know if you've had the pleasure of talking to a physician and relaying their patient satisfaction score to them, but they are very happy to tell you about the challenges of changing patient demographics, that it's very hard when the patients are older, they're sicker, they're more culturally and linguistically diverse, and even the ones that you are connected to, well, they've already contacted Dr. Google or ChatGPT. They come to you not asking for your help. They come to you telling you what they want. Quite often they're demanding opioids, and when we deny them, we see them return and wreak violence on our institutions. So if you think we could get rid of patient satisfaction scores and that'll solve the problem, I invite you to just take your phone out right now and Yelp yourself and see how your practice stacks up in Yelp. You might be surprised, and we have no control over that. We could turn to our professional societies for help with maintenance of certification, which is slowly getting better, but has been a real challenge for many physicians, where we're spending many dollars and many hours to prepare to take a test that sort of kind of demonstrates our competence. As health systems look at this, they think the only way we can manage this is to get bigger so we can handle the government, we can handle the insurance companies. So let's merge, or let's have a PE company take us over. And yet that brings its own set of challenges with it, because now the leadership are distracted away from all these operational issues at the front line, and they're focused on things that as leaders may feel a little more sexy, like all the legal and financial things to work through. Thankfully, the federal government has helped us year on year by reducing Medicare reimbursement rates every year. So when you look at this, you wonder, why does anybody even why are we all in the profession? Well, we're in the profession because as long as we can hang on to those things that give us professional fulfillment, we've figured out how to deal with each of these little challenges. And we could go around the room here and go around the virtual room, and almost every single person could add yet one more unique thing into that circle. This is not a comprehensive list. But when you think about the impact, in fact, there's many aspects of the impact that people don't know about. Part of it is just the cognitive overload that all of this brings. And what happens with that cognitive overload? There's a science of human factors engineering that studies this. And what they have shown is the impact on the brain of overload. We see elevated cortisol levels reducing blood flow to the brain, elevated glutamate levels decreasing fine motor control, thinning of the prefrontal cortex, impacts decision-making. Enlargement of the amygdala increases reactivity to stress. Well, I've never reacted to stress as a doctor, but I hear some people do. And shrinking of the hippocampus, so it hurts our short-term memory. These are the brains of the physicians. Half the physicians in your organization are experiencing these realities. These are the brains of the people taking care of you. These are the brains of the people that are responsible for generating all of the work that keeps our enterprises going. But this is the real impact on those brains. And the downstream impact of that is that clinicians are suffering with injuries, depression, substance abuse, family dysfunction, and suicide. The national trends do not look good. Physician shortages are growing. We're looking at a physician shortage of 15 to 18% over the next 10 years. And practice models are not helping because most physicians now are not independent. They do not have control. They're either working for a corporate entity or for a hospital or health system, and some have trouble distinguishing between the two. PE, private equity, is growing like crazy. Some people have found PE to work well, but many people have found that the push for profits is so strong that they're finding reduction in support for their work once they've made that move into being supported by private equity. Physicians aren't really feeling very good about any of this. 60 or 70% think that hospitals really focus on financial gain over the quality of care, that it's harder to coordinate care, and that PE is not good for healthcare delivery. They're not hopeful for the future. Only 40% would recommend medicine as a profession for young people who are considering what their job should be. And whether it's the current status or the future status, less than a third are feeling positive about that. Burned out brains don't function well, and when we're not functioning well, our work performance worsens, and in a value-based system, there's less reimbursement per unit of service if the value decreases. And in an effort to cope with all of this, physicians are cutting back. If they're not leaving the profession altogether, they're figuring out how much they can cut back and still maintain their lifestyle and their benefits. Can it be, instead of working one full FTE, can it be 0.9, 0.8, 0.7, even 0.6? But as we're working less, we're producing fewer units of service, which have the potential to be paid less per unit of service. It's not an equation that's going to turn into healthy healthcare system finances. So administrators are burning out as well, now at the same rates that physicians are. 10 years ago, that was not the case. 10 years ago, administrators burned out at about the same rate that the general public did. But things have gotten so challenging and so complex. This is where we're at. So the current state really does appear unsustainable. We've seen the biggest increases in emotional exhaustion. In-basket messages have increased 350%. In fact, I've been told that ICD-12 is adding a new code just for physicians that manage in-baskets. It's called portal hypertension because they're so overwhelmed. And just this year, already 21 hospitals have closed due to financial failure. The question becomes, how do we deal with this? Can we actually do two things at once? Beat burnout and create sustainable healthcare systems. We think we can. And there's this well-known model, the Stanford WellMD model of professional fulfillment, that we can use as a framework in which to work. The first step in that is personal resilience. And in focusing on personal resilience, this is where we see chief wellness officers come into play, and where there's a focus on enhancing the resilience of clinicians, looking at both their individual factors and providing peer support. One of the keys for me with personal resilience is this concept that self-care is not selfish. As we think about when we choose to go into the profession, we're here to take care of others, and there's so much to learn, so much to do. We sometimes think if I'm spending time taking care of myself, I'm not spending enough time doing my profession, which is taking care of others, until we realize that if we're not whole, There's no way we can take care of others well. But this is a tough mental switch to make. Secondly, this work is vitally important because things are so bad. But it is also absolutely insufficient. And frankly, in ways insulting to people who we know are the most resilient people in the world, if all your organization is offering is resilience support. If the organization admits there's burnout, and they offer resilience support, but they offer no other way to reduce the drivers of burnout, they're completely showing a misunderstanding of the issue, and quite frankly, a lack of respect for the people that are burning out. So what else do we do? The next is efficiency of practice, and you know what? This is what doctors care about the most. Can I spend as much time as possible doing what I love? And how do we make it so that we can actually do that? Because none of us signed up to practice like this. If you haven't seen this picture before, it was published about 12 years ago in JAMA. It was drawn by a very grateful pediatric patient, drawing a picture of her experience in the exam room with the pediatrician that she loved very much. You can see him over there on the left, happily typing away into his computer and ignoring the family, his patient and the family in the room. He was appalled when he saw this. And we should still remain appalled when we see this, but this is still the reality for too many clinicians. I maintain we actually have an opportunity to what we call flip the ratio. What ratio? Remember we talked about we only spend 1/3 of our time on meaningful work and 2/3 of our time is on wasteful administrivia. Just imagine if we flip that and we spent 2/3 of our time on meaningful work and 1/3 of our time maybe on necessary waste. What would that mean for work-life balance and focus on patient care and increasing productivity without burning out? The question is, how do you do that? Well, AMA has this great acronym now called GROSS. It stands for Get Rid of Stupid Stuff. It's fun to say. The question is, how do you really do that? Because there are so few organizations that we see that are really focused on this right now. There's 3 key steps. First is doing in-depth, thoughtful workflow redesign, really looking from start to finish, understanding every step in the process, bringing together the multiple stakeholders that are involved in these processes, all collaborating to identify the steps, identify what's not necessary, and testing new approaches to work through it. A lot of places have dabbled in this, or they've done it in one little corner of their organization, but it's rare for us to see this work being done comprehensively. It's also rare for us to see physicians deeply involved in this work. And yet people are redesigning our workflows for us when we're not present in that workflow redesign. When physicians are employed or not, this is real work. Physicians should be paid for this work. It's not something that's secondary, but we need to be engaged. We can't make the excuse, oh, my patients need me, or my colleagues need me, so I can't be involved in redesigning the way patients move through the system. Because if our patients really needed us that desperately and our colleagues needed us that desperately, we'd never take time off or go to a CME course. This work is the most important work we do when we're not directly caring for patients, redesigning the work the way it's done so our work is more effective. The next step, and this goes hand in hand with this, are daily huddles. Now, when we say huddles, I say that with a bit of apprehension because I bet everybody in this room has attended a huddle that sucked. Huddles can really, if they're not done well, they can be demoralizing. But when they're done right, they are a key to a successful day. They have to have 4 key components. One is appreciation. What did somebody do yesterday that made a difference for me? Addressing that driver of insufficient reward and recognition. Second, prepare for the day. What's the demand coming at us compared to the capacity we have to deal with it? Quite often we don't have the capacity, but we can build contingency plans that allow us to then successfully get through that day. Next is looking at how are we actually improving our performance by tracking metrics that are relevant to that work unit. These are process metrics, not the outcome metric of some number that happens downstream. But what are we doing? What are the activities we're doing that help drive that improvement? And are we actually able to do the ones we're asking ourselves to do? And lastly, solving problems. Little things that drive you crazy when they happen. But you swear you're never going to let it happen again because it got you so thrown. And by the end of the day, you're too tired to remember it. And by the next week, when it happens again, you're even more upset. If we take that little problem when it happens that day, put it on the huddle board and talk about it the next morning with the team and decide, is this something we all want to work on? And yes, we will. Okay, let's have a small team work on it, bring it back next week, and we'll see what we've got going. Local control over our day, over our problems, over our performance is absolutely key. Most huddles are not structured this way, but when they are transformative, and we have seen them spread across entire organizations and dramatically change the culture of the organization. And lastly, technology. 20 years ago when the EHR came in, it was damaging. It created a lot of the waste. We are now at the point with AI, with ambient listening to reduce data entry burden, with the ability to comb through a chart and provide a physician information they need at the moment they're going in to see that patient, or to provide valuable clinical decision support that's very specific to that particular patient's mix of pathologic challenges. That when we put these together, and particularly when we implement them using workflow redesign and fine-tune them as they get put into place through the huddle, we can make a true difference. I'm very worried that all the AI will get put into place, but not thoughtfully enough, where we'll end up with other problems coming up as a result because we haven't worked through this process. To flip this ratio, all three of these components are necessary. All three of them can work well. We've seen it work, and we know there's the opportunity, but so few organizations are really committed to this. It takes an investment up front, but it pays off in spades down the line. And lastly, the culture of wellness. This really is about leadership and culture and reducing that cynicism. And here, this is, I think, our chance to create a new relationship between senior leaders and physicians. Right now, there's deep mutual distrust and disrespect in many organizations between the senior leaders, those people up in the C-suite, and the physicians on the front line. And it does not have to be this way. The key to get started with this change is to recognize that physicians are knowledge workers. That's a term that got coined by Peter Drucker, the man in the picture here, the father of modern management, as most places that teach business leadership and administration know. And he defined knowledge workers, he said they value leadership but not management, that they think for a living, that they're problem solvers who know more than their manager knows about the work they're doing. They innovate all day long, and autonomy is a necessity. Kind of sounds like doctors to me. In fact, for 25 years practicing as a family doctor, slowly burning out, I craved the autonomy to fix what was wrong in my office every day. Then I became the CEO of this 300 physician group. Suddenly the thought of all 300 doctors being autonomously empowered scared me, that we would fall apart from entropy if we weren't careful. And it was hard because at that time I took over, I was given the honor of having that position. We were $9 million in debt. The pressure on me to turn that around was intense, and I was so tempted to issue mandates and micromanage. But I knew if I did that, it would not work, and it would create big problems in the long run. Instead, I was fortunate to find a way, a different approach, an approach of servant leadership, which is a term that gets thrown around a lot these days. And many people do not understand how to do this in an effective way. Some people think it's all about being of service, but if you're just a servant, the inmates can start to run the asylum. If it's all about leadership and we don't know how to actually lead the people we're serving, that becomes a problem as well. The key is some core concepts around empowering people to act locally, to solve the problems that they identify in their work area, and to align everyone thinking globally, aligning around the values that bring meaning to our work. Sounds good. How do you do that? I mean, that's one thing to say it. It's a whole other thing to think about how we do it. Particularly because this kind of change, radical change in a culture, takes courage. It's the one leadership role that cannot be delegated to anybody else. When the senior leader says, oh, we have a problem with burnout, I'm going to hire a chief wellness officer and that'll solve the problem, we're missing the point. This is where the senior leader needs to be deeply engaged because we're leading culture change. And that senior leader needs to be out there being seen and heard by everybody so people believe it's actually happening. Hardwiring that respect for people is a challenge, particularly from where we're starting. I had the experience after I was CEO, and I'll talk a little more about the results we got. I was invited to join this consulting firm that actually I'd hired to help us lead the transformation in my organization. And the first thing they did was send me to this conference called the Association for Manufacturing Excellence. And I thought, what am I going to learn from a bunch of manufacturers, people who make garage doors and widgets? I'm in healthcare. We have a noble mission. What can I possibly learn from these people? And then I met this gentleman, Bob Chapman, who runs a large manufacturing firm and conglomerate. Got like 80 plants in 20 countries all over the world, $3 billion in revenue, outperforms Warren Buffett and Berkshire Hathaway on return on equity. And the key to his success was when he realized that he had an opportunity to change his organization. He was a top-down command and control manager. And he wondered, what would happen if I started treating every one of my employees the same way I care about my close friends and family? And I created that sense within every one of my organization, within every one of my plants. So these places where people are making bottle washers for Budweiser have this deep, caring relationship within the plant itself. And I came away embarrassed for healthcare because I know how harsh we are on each other compared to what Bob was able to achieve. Same thing happened at Alcoa. This is Paul O'Neill, who was not only the Secretary of the Treasury of the United States of America, he was also CEO of Alcoa and the founder of the Pittsburgh Regional Health Initiative, because he cared so deeply about making healthcare better when he saw how sorry it was compared to what Alcoa was like after he led Alcoa. Because he led it with focus on these three questions. First one, he wanted everyone in his organization to be able to answer yes to, am I treated every day with dignity and respect by every single person I encounter? So whether it's the cardiovascular surgeon or the neurosurgeon, are they treating everybody with respect? The receptionist, the transport person, the EVS person. Am I given the resources I need in order to make a contribution to my organization that gives meaning to my life? Do I have what I need to do the job that I'm craving to do? And am I recognized and thanked for doing this? These three questions drove his turnaround of Alcoa. Basically, both of them were creating psychological safety, which we desperately need to heal this broken culture that we have in medicine. Amy Edmondson is the primary spokesperson for psychological safety, professor here in Boston at Harvard, or close by in Boston at Harvard. And the basics of psychological safety are that you know you will not be punished or humiliated for speaking up with ideas or questions, concerns, or making a mistake. Not the seminal experience we all had learning leadership, making rounds as medical students and fellows and residents in healthcare. I distinctly remember being humiliated many times with somehow the thought in the back of someone's mind that if I was humiliated, I would study harder and learn more. I think this is the deep basis for a lot of our challenges. To get there, we need to design organizations that support clinicians to care for patients, because the patient is the most important person in the organization. And the most important thing that happens to that most important person is that healing interaction between everyone on the front lines and that patient. Whether doctor, nurse, receptionist, technician, therapist, transport person, EVS person, anytime we interact with a patient, we have a chance to make it healing, to reduce anxiety or worry, relieve pain or suffering, or do a procedure that makes a difference, educate people to be healthier. As a family doctor for 25 years, I had close to 100,000 healing interactions in my career. Then I became the CEO, that person at the bottom of the slide there. I was no longer doing the most important thing for the most important person. I wasn't seeing patients any longer. My job became to make sure that the people between me and the people on the front lines knew that their job was to make sure the caregivers on the front lines had what they needed to do so they could do their job well. And we structured that. We actually redesigned our org chart and built it around dyad and triad teams so that administrators and clinicians worked together at every level and helped break that divide between administration and clinicians. And we also made sure that our support service people, HR, finance, and IT knew their primary job was to make sure those folks on the front lines have what they needed to do their jobs well. This was a big change for everyone to go through. It wasn't easy. It was a lot harder than I thought it was going to be at first, but the payoff down the line was significant. Leaders doing this need to round to see and to be seen. One of the questions I often get asked is, well, if you're a physician, great. So you were seeing patients and you were leading, so you could really feel the pain of the doctors. And honestly, I stopped seeing patients when I became the CEO. I just didn't feel I could do enough clinical care to maintain my competence well enough. But I substituted it with shadowing. I would shadow clinicians in all the different specialties and experience all of their different levels of pain, rather than simply what I knew as an urgent care family practice doctor. And this is something anyone can do. It's a little intimidating at first, particularly for non-clinicians, but done right and with support, it's transformative. And if you're really brave, as a leader, take the entire leadership team and the board of directors and put everybody in scrubs and booties for a day and have them follow around a few different clinicians in different aspects of the job, and then debrief at the end of that day and see what people have learned. They'll learn more in one day than they learned in 6 years as a board member by having an experience like this. We need to align around these shared values that bring meaning to our work. And it sounds great, but it's actually very hard work, particularly when we're in this atmosphere of mergers and acquisitions, because we'll think that all of our different health organizations, we're all pretty much the same. We're here to care for patients. We have this noble mission. But when you get right down to how each organization works, what their cultures are like, they can be very different. There's a process to go through called a compact that can help identify in detail how we each look at our values, how we can then find a way to share common values and express them in reciprocal agreements that not only say, if we're honoring this value, we expect this behavior from our people, but to honor this value and expect that behavior, the organization will also reciprocally provide the support that's needed to be sure people can do that work. And another way to connect clinicians to the senior leaders is through tiered huddles. So those huddles that happen on the front line get followed by a sequence of huddles to the C-suite, where information flows up and then support flows back out to the front lines. That may sound sort of Pollyannish, like, well, it looks good. I don't think it could ever happen in our organization. It happened in every healthcare organization 4 years ago. When COVID hit, every organization scrambled to protect the people on the front lines. Command center meetings were happening 2 and 3 times a day to make sure that senior leaders and everyone they were coordinating were doing everything they could to know what was wrong at the front lines, to come up with solutions and get those solutions dispersed back out, because people were truly under an existential threat. Now, we may not be under the same level of existential threat as the pandemic, and it would be pretty much impossible to maintain that level of urgency over this length of time. But my sense, as I go around the country and look at many different health systems, is that we have a lesson we learned 4 years ago, and rather than continue to use it to some degree, it's been basically forgotten and abandoned, and we're now still trying to figure out how can we solve this problem of burnout and staffing shortage and financial weaknesses. The places that figure it out and move from personal resilience to organizational resilience by empowering people so they can collaborate and quickly solve problems, they're doing what Darwin said. Doesn't matter how strong, smart, or fast you are. I don't think he mentioned market share as being a factor, but it's also a factor. The key to survival is being the most responsive to change. And this works. As CEO of the Sutter Gould Medical Foundation in Modesto, California, 300 physicians and 1,100 staff when I got there, we put this system into place. 4 years later, we got recognized by Consumer Reports as providing the highest level of patient care among 170 other medical groups across the state of California 2 years in a row. We didn't even know they were doing this survey in conjunction with the California Health Performance Institute. One day, one of my doctors came walking in with a copy of Consumer Reports in his hand and says, "Hey, look, we're the best in the state." We were floored. And we did not do it on the back. Our doctors thrived. Their professional satisfaction soared from the 45th to the 87th percentile. And honestly, there's really nothing special about me compared to anyone else who leads an organization like this. It's a matter of connecting all these dots and making that commitment to creating a great place to work where people can thrive. And then we can address the things that are driving that burnout and frustrating us. So my question, we're getting close to the end here so we can have questions and answers, is what will you do differently? Our suggestion, if you're close to the front lines, you should be working on work overload. Whether that's redesigning steps or having that meaningful daily huddle, not the crappy daily huddle, but the huddle that actually makes a difference. If you're in senior leadership position, your job is to change the culture so that we superpower our ability to do that work overload. Because burnout, now we know, it's harm is done to an individual by dysfunction in the workplace. And we've allowed the dysfunction to go on for too long. We lose 300 to 400 physicians a year, whether it's Benjamin Schaffer, who we lost before the pandemic, Lorna Breen, who was lost during the pandemic, or just this year, Will West, who has been lost after the pandemic. It's past time for a real commitment for senior leaders and physicians to collaborate. We both need to step out of our defensive shells and reach out to each other to make a difference. Because then we can take real and urgent action together. As Gandhi said, you have to be the change you want to see happen in the world. We can't just sit here and say, well, that would be great. You go first. We have to do it. So my question to you as we lead into the discussion is, what action will you take tomorrow? You may be sitting here thinking, ooh, there's a lot of heavy stuff there. There's no way I can go in and redesign an org chart. You don't have to. You can do something as simple. If you have a small team, thank somebody on that team tomorrow for something they did, specifically stating what it was and what a difference it made for them. Or if you're in a high leadership position, you can either go shadow one of your clinicians tomorrow. It really doesn't, you don't have to have a whole formal plan in place. Or if that's not really quite right, go ask somebody on the front lines what they think you as a senior leader need to know so you can help them do their jobs better. Those kind of simple actions can start the process. Sure, there's a lot to put together in a big way, but these are the kind of steps we can take. Quite honestly, my partner, Bruce Cummings, here is sitting right here in the middle of the room. Bruce and I together work in a company we call Organizational Wellbeing Solutions. We go to many healthcare organizations. We present these concepts to many healthcare organizations. They tell us, thank you very much. Now that you've told us what to do, we'll take it from here. We've never seen one of them actually make the change. Because it sounds good, but it's hard. And people get overwhelmed by all of the other activities and demands coming at them. So it takes help. In fact, I've never seen it happen without someone from the outside helping coach senior leaders. Someone who has had the experience of leading such change and has the confidence to tell senior leaders those hard truths they need to hear, but like any of us, really would rather not be told. But now is the time. Now we have the opportunity. And I would love to hear from you all what you think you can do, or where you think what I've presented really maybe isn't right or needs some tweaking, could be done better, because we're constantly learning through this whole process as well. So I really appreciate it. Thank you very much. And I look forward to a great discussion. Oh, and by the way, for those of you in the room, my co-author Diane Shannon of this book, we've got a number of books here that we are happy to sign for you and you can take home with you if you would like.
Are there questions online?
There are a couple of questions online. Do you want to start there? Does anyone in the room want to ask a question first?
Start with online.
All right, so the first question that we have are thoughts about free medical education, like in the UK, no debt, therefore lower salaries, and draws altruistic doctors without attracting people focused too much on financial gain. There's a little bit of just a follow-up that I can share with you after, but the first question is just about your thoughts
Sure.
on free medical education.
So certainly reducing medical education debt is incredibly important. Any one of these things, though, on its own is not a panacea. I don't know if people follow what happens in the UK very much, but there are other factors driving incredible levels of burnout in the UK. A lot of them around leadership and demand, and since it's government run, the current governments have made decisions about how healthcare should be practiced, how physicians should be reimbursed, what their panel sizes should be, that have driven significant burnout in the UK as well. So it's certainly the less, if we come out of med school with less debt, we can make better choices about which specialties to go into and how to practice, no question about it. And it would be a great step in conjunction with many other activities.
Is there a follow-up? Is anybody in the room? Livia?
Thank you so much, Dr. DeChant, for your wonderful talk. I think that was really very inspiring. It's ironic that we would like to respect and ask our workers, do they feel they are valued? Do they feel that they are given the resources that they need? We ourselves as doctors in the big scheme of pictures is not getting that from Medicare, is not getting that from our payers. We're not valued. We're not given the resources that we need. So what are your thoughts about that?
Yeah, so thank you, that you're right. This talk could be expanded further. You know, the picture I had with the circles where the physician's in the middle and then there's the clinical workplace and then there's the external factors. Some of those external factors are so intense and so overwhelming. And we need to find ways to deal with those also. One of the AMA, actually, I don't know, many people have a love-hate relationship with the AMA. They have committed significantly over the last 10 years to address this issue of burnout in the approaches that and a lot of their work actually is focused on redesigning workflows and addressing those challenges, but they also are addressing regulatory and legislative issues and are advocating around the issues of prior auth and other insurer abuse of the system. So there's a whole array of options that we need to be pursuing. And unfortunately, we have to do them kind of all at the same time because otherwise it's like whack-a-mole. You will never get caught up. And it's not, I'm not hopeful that in 3 years or even 5 years we'll have this solved, but we'll be a lot farther down the road if we all come together and work at it. But these issues of regulatory challenges, of the legal challenges that, new laws that come out, or the way that Medicare decides to reimburse physicians, the whole MedPAC, all of that, all of it's contributing to the problem. And so wherever we have skills, knowledge, and talent to apply that, we need to be doing so for sure.
The back row.
I appreciate 2 points. Just a little bit of a
Can you
follow-up.
speak up, please?
Yes.
Can we get the mic up to?
One question about medical education. There was an article recently in The Atlantic about a very interesting outcome in the few medical schools that have become free in the United States. I would suggest people take a look at that. And I think the major difference between those in the UK, despite everything else going on in the UK, is that everybody gets free tuition in the UK. And I think the interesting thing that came up in the Atlantic article about how the few schools that are free from what's going on as far as their student demographics and what students are going into specialties versus primary care and all that. It's an interesting study. My second was, the hairs on the back of my neck stand up every time we talk about private equity. It seems such a corruption of values to have these two things in any. And I wonder, it's, I sort of know the old adage is sort of putting lipstick on a pig. We should never have lipstick together in the first place, because no matter what you do, it's not going to look right. And I'm wondering if we're really looking at the wrong end of this, and really should be advocating much more, pulling back that sort of model, especially with what's happened with the hospitals in this particular state most recently. It was interesting, we had one of our Health and Human Services secretaries on the board of that hospital system. You would think there'd be some protection there, and it's really shocking to sort of see what had happened to that whole system. So I think I'm a little bit more inclined to think that we need to be getting at that root cause a little bit more. And instead of trying to fix it on the end once it's been done, maybe pulling back from having that happen in the first place. I feel like that's probably a legislative solution more than anything else. And I know you haven't talked about those solutions, but I was wondering if that's something that you consider.
Sure. So, yeah, thanks, Rick. You're right. So just for everybody to be able to hear that, I don't know, can we maybe for the next ones, we could move the mic around, but I'll try.
But they might not catch the.
Oh, okay. To address the second question first about private equity, there's, if all the players were honorable and pursuing the right thing, however we all define that, there's a lot of efficiency that good business practices can bring that could actually create a better clinical environment as well. But they oftentimes, it's too easy for people to start to pursue one aspect and just pursue the profit to the detriment of the care. No question about it. There need to be guardrails. Many of the not-for-profit health systems have a medical loss ratio requirement of 85%, which means that only 15% of the money that goes into a health insurance company can be held back from patient care to pay for administration and marketing and things like that. I don't believe that exists for private equity. Maybe that's a legislative solution to pursue. The other question around, well, actually it was more of an observation about the free medical school in the US versus the UK and what's happening with those. And just you're recommending people go to the Atlantic to read that article. That would be interesting to see. Because at the root of it, so much of it is about money, whether it's private equity or how we fund medical school or any number of other issues involved. And it's a complex issue, and we need to be addressing it on all fronts, no question about it. So the AMA is doing a lot with this. It's worth getting involved there. The physician who I've known now for well over a decade, who leads the AMA's efforts in this is Dr. Christine Sinsky. And she's done amazing work both on practice efficiency and on these bigger regulatory and financing issues. And they actually have committed a significant portion now of all of the AMA's resources and efforts just on these issues. There's an excellent website with many, many resources in it called Steps Forward that's sponsored by the AMA. And if you're looking for anything, whether it's simple solutions to change things in your office, how to lead or connect to your senior leadership, or any number of other issues, including regulatory things, it's key. In fact, one of the things that happens inside health systems is the leadership can overinterpret the regulations and insist that we do things that we really don't have to do that hinder our ability to make improvements. 10 years ago, as CEO at Sutter Gould, we were putting into place team care approaches where our medical assistants were doing many functions that people got concerned might be outside their scope of practice. And we had a memo war going back and forth with the compliance officers at Sutter Health and our doctors that were putting this into place. And finally, we just had the compliance officer come down and observe for half a day what we were doing. And after months of memo wars, they spent a couple hours observing and said, oh, this is fine. This is okay. We get so easily caught up in the fine points of wording that we sometimes miss the reality or the main message that's underneath it all. So the more we can get people together to look at it, and the more we are really careful to not overinterpret a regulation for fear that somehow we're going to violate compliance, is really an important thing to do internally to deal with these external factors as well. Yes, sir.
Of course, it's too late for most of us sitting.
Let's see if this. There we go.
So I think it's too late for most of us sitting in this room, but as we advise students and interns, are there specialties and or modes of practice that result in less physician burnout?
Oh, that's a great question. Thank you. So specialties, the range of burnout is somewhere between 70% and 40% across all specialties. So even 40% of dermatologists and ophthalmologists are burned out. You would think, my gosh, of all the specialties, how could that happen? Whereas emergency medicine and primary care people are burned out at closer to those 70% ranges. And different other specialties seem to pop up over the years, varying urology, orthopedics, you name it. The thing I think that's most important is to find, at a deeper kind of conceptual level, is to find your opportunities for autonomy. In primary care, what's happening, a big movement that provides autonomy is the direct primary care movement. And for those of you not familiar, that's oftentimes was originally referred to as a concierge movement of you make an agreement with your physician, you pay them X dollars per month and they take care of you and you get much more personal attention. In fact, places are finding that it can reduce the global cost of care because as your doctor has more time with you, they're then not going to order a whole bunch of extensive tests to try to make up for the time they don't have with you to figure out what's wrong. But that autonomy is huge for primary care. I have seen specialists, particularly people who are doing locum tenens work, because they can't stand being in the milieu anymore, actually start to gain autonomy by not going through a locums company, but going directly to a hospital and agreeing with the hospital to provide their locums care. The physician gets a higher salary, the hospital saves some money, and it creates a level of autonomy. And these are starting to really catch on, this whole concept of how do I get back that autonomy that is such a deeply held value as it should be for physicians. So those are, I think, at a broad brush, the things to look at.
Yeah, so I asked. Test. So I asked this question as not a doctor. I am a financial advisor, and I'm kind of curious to see, how much does debt play into your overall stress? I was kind of interested to see the fact that you said 40% of. Actually, I don't remember the statistic that you posted. It saw something with 40%, but regarding the heavy amounts of debt you end up having to pay, how much does that play into your overall burnout and stress?
Yeah. Well, it varies a lot by person and by what their particular financial situation is, because a lot of people find ways to finance it through working for the public health service or the military or a scholarship or any number of things. But it's significant. When people, the average physician graduating is somewhere around $300,000 in debt when they graduate medical school. Now, they're around 30 years old. They don't have a house. They don't have a retirement plan. They don't have anything else. They're $300,000 in debt with no other assets built up yet. Doing financial advising, most 30-year-olds are getting some kind of base now, although it's getting tougher and tougher even for everybody in the young age groups to make it. But there's that extra burden, and it can be huge. And so many people will choose a specialty that reimburses at a higher rate, and particularly avoid primary care because of that. So it definitely has an impact. Anything online?
There are, but I think you've covered smattering.
Okay.
Good question.
Thank you for the talk. And also thank you for talking about the philosophy behind what you're doing. I am very interested in servant leadership. At the library, this is what we use in our management team. Sometimes we're very, very successful with it. Other times, depending on the outside forces at play, it doesn't always work. Could you tell me why you chose this particular philosophy of management?
Wow. That's not a very fair question. No, I say that jokingly. You know, as we went through the changes that in the leadership I had of that group, I really was just thinking, what would I want as a family doctor, as any doctor working in the group, how would I want to be treated? And could we put into place the things that would allow me to function the way I wanted to function? And so I really hadn't thought deeply about servant leadership as a concept in the process. It was more a matter of figuring out, how do we help individuals who are highly motivated professionals seeking that fulfillment and the organization itself collaboratively succeed. So there was certainly some trial and error in the process. In retrospect, now looking back, 10 years later, being able to, having done more research, having done more reading, learning more about modes of leadership, it's become clear to me why what we did worked and how it worked out. But in the middle of it, it was just kind of, let's try it. It was more confusion and let's try it than an intentional approach. I think overall, I think businesses as a whole are starting to understand this more and more and are starting to find ways to do it. And we see it in multiple different industries, not just in healthcare. I wish I'd been that intentional and knew that much about it as I had gone into it, but it really was trial and error and finding the way. And now to being able to explain it with some frameworks certainly helps. Much better than saying, "Oh, I don't know, I tried it, you try it." It's the frameworks are there, they really do make a difference. And there's a lot of great educators about servant leadership that can help provide guidance. People like Simon Sinek and his books, Leaders Eat Last or Start With Why. There's Marshall Goldsmith, who talks about how you have to ask your people what they think of how you're leading and how they would like to see you lead more effectively. Adam Grant talks about being a giver more than a taker as a leader and being willing to take chances and being a bit of an outlier. So there's a number of really great people that provide guidance around this that you can read or learn from. Yeah.
Thank you.
Thank you, Paul. Great talk.
Thank
Thank you
you.
very much.
I'll just say apologies to everybody online who asked a question that we weren't able to answer. And I would just recommend reaching out to Dr. DeChant via your
Sure.
contact information on the screen
Absolutely.
with any
Yeah.
other questions
Yeah,
that weren't
people
answered.
can reach me, email me directly or any other way you see with contact info up there. Happy to engage in a discussion.
Thank you.
Want your CME, please respond to the survey link that you're. Please respond to the survey link that you're going to get tomorrow if you want your CME. Thank you all for coming. Thank you for joining us online. Have a good night.
Thank you.